I hope everyone enjoyed the first session. We have some more great topics to discuss now. So it looks like our slides are back up and running. So without further ado, I'd like to introduce Kasha Singh. Kasha is an infectious diseases physician in Melbourne with expertise in tuberculosis, HIV, and antimicrobial stewardship. She completed a PhD in liver disease pathogenesis in HIV and hepatitis B co-infection. Kasha has extensive experience in clinical trials and TB program implementation across diverse international settings. Her work focuses on managing co-infections in people living with HIV and optimising treatment outcomes. She has a particular interest in management of complex drug-related toxicities in TB and HIV care. Kasha will be discussing the updates to the tuberculosis and diphtheria topics in Therapeutic Guidelines. Please join me in welcoming Kasha to the stage.
Thank you. Thanks, Brad. It's a real privilege to be here amongst friends. I'd like to add my acknowledgement of the traditional owners, especially in Nibeluna, Hobart. The injustices of the past feel especially poignant, with the amazing stories of Tasmania and the striking landscapes. It always hits hard here. I'd also like to echo Crispin's comments about what it's been like to be involved in this project and this team. It's a real honour and a privilege being a part of the enlightening, stimulating, often robust discussion that happens and spending time with people who are so committed to trying to make these guidelines the best they can be within the limitations that we have. Has been a really, it's been a great process to be a part of. So I'm going to go through a couple of things. In tuberculosis, which is not a new topic in these guidelines, I want to talk a little bit about the sort of things that we've updated. And I've kind of given a bit of an overview here. There's a little bit about terminology that Crispin's kindly given me a opening comment about. Also about transmission and how we talk about it. So a lot of these first two topics are around language and how it's changed a bit, which reflects changes in the field and our understanding of TB in general. Diagnostics is something that's really changed in TB since the last update, and really it's been the advent of molecular diagnostics. Now, there was a lot of discussion around this because certainly a problem we often have with when you get new diagnostics, new things are available, is they're not available to everyone and in all settings, and we do acknowledge that. But it's sort of thought now on a global scale that this is a kind of standard of care that we should be able to have accessible. So a lot of thought was put into it, but recognising some of the limitations. One of the things there is less about is new treatments for TB, and we'll go on to discuss that. There certainly has been quite a bit of space in the management of drug-resistant TB, but that is a little beyond the scope of these guidelines. And so it's sort of striking to me, with all the advances in understanding we have made in TB, the treatment shortening trials in tuberculosis have largely been unsuccessful. So it's an interesting thing in itself. And finally, the recognition that TB doesn't always just stop at the end of treatment. So, terminology update. Latent TB becomes TB infection. So we've really been moving to understand tuberculosis, infection and treatment as a spectrum, infection and disease as a spectrum, rather than a dichotomy. And this table was presented at the conference. So this is a paper taken from Lancet Respiratory Medicine, and Anna Cousins works at WEHI in Victoria, or she did, and is a TB researcher from South Africa. And she presented this massive body of work, really, which looked at how we understand TB and the evidence behind why our understanding is shifting. And really, this is for research purposes rather than clinical purposes, so how we classify TB is changing. And there are disease dimensions, which are pathology and signs and symptoms, but then also infectiousness, which is neither but both. And then along the different rows there, you can see the terminology, which is clunky. So TB infections, subclinical TB that may be non-infectious or infectious, clinical TB that may be non-infectious, and clinical TB which is infectious. And this really is contrary to what we always used to understand, which is you had to have symptoms to be infectious, you had to have symptoms to have disease. And part of our understanding and the way that's evolved has been new technology such as PET scanning and things, but also longitudinal studies looking at what happens in the end in patients who have TB infection and what different pathway they go through, and that they can fluctuate over time. So that is something we now don't really refer to latent TB. TB infection, though, is not as intuitive in many ways, and particularly in explaining things to patients, it can be a bit hard to explain this spectrum to them, and I'm still grappling with that myself. TB infection is what's diagnosed by a positive skin test or a TB-specific interferon gamma release assays, and it's beyond the scope of this to talk about the limitations of those, but tools for assessing your risk of progression have advanced a bit. So Periscope's newer, and TST in 3D is a new iteration of the TST calculator, so they can be useful in trying to explain to patients. I write very messy diagrams about TB, and I'm not quite sure how much of it is really useful, but it's something I've been working on. So these guidelines will now reflect that. Infection control is a really big one, and our understanding of that has changed quite a lot. In particular, how quickly people with TB infection requiring treatment, so TB disease, become non-infectious. And also our increasing understanding of the dangers of prolonged, or the morbidity associated with prolonged respiratory restriction and isolation. So this is taken from the National TB Coalition of America, published in 2024, and has basically given an overview of that, but also a really solid evidence base behind it. So this has lots of references, and it refers to models, so human to guinea pig transmission that have been used in TB a lot, to PK studies, to looking at early bactericidal activity and the drop in bacterial load, and also looking at a lot of studies and work that's been done about transmission and who's really at risk. We think that TB treatment probably has an effect on transmission very early on, and that we now know that sputum culture positivity, PCR positivity, and those markers are probably not particularly useful in helping us understand who's infectious and who is not. So that's quite a big change. It helps us quite a lot in management, particularly in the community. In your hospital setting, things are likely to be a little bit different, and hospital guidelines, and because of the people who are immunosuppressed in a hospital environment and close contacts may well be a little bit different. But it's quite a useful document to refer to. So they use the number of 5 days here as being non-infectious or having a low likelihood of infectiousness, and being able, therefore, to be out of isolation in a community setting. And that being regardless of sputum bacteriological status. The main thing is knowing that the treatment they're on is effective, so drug susceptibility results being available to know that, and that they are taking it. The bit in the box on the top left is the extract taken from Therapeutic Guidelines that's now online. And there's a few of those, like in Karen's talk, just to show what this looks like in the guideline now. This is taken again from that document, the SHAR paper from 2024, and elaborates a bit more. No single test or anti-tuberculous therapy duration predicts non-infectiousness, and that there is individual variability, but available evidence indicates that most PWTB people with tuberculosis are unlikely to transmit to others after the first few days, so this states 72 hours, of treatment initiation. Community-based respiratory isolation and restriction can be discontinued, therefore, in most cases, and this gives the window of 48 hours later, so after 5 days of anti-tuberculous therapy. And they give a few exceptions, including exposures to people who might be particularly susceptible, and in particular settings where those extension to that might be warranted. And I'd suggest that hospitals will probably remain one of those. Moving on to diagnostics, molecular testing now becoming central. So we list these, we still do list culture and microscopy for acid-fast bacilli, but also nucleic acid amplification testing, or PCR, in many settings. That means a gene expert test, and there are a range of these. So also have a range of availabilities. And the other thing that is now being done in a lot of the TB programs statewide is whole genome sequencing for susceptibility testing as well. This has become a standard of care in some parts of the world, and we are probably also moving towards that in Australia. The time frame around those results being available, though, will be variable depending on where you are. So at my primary place of work, we have a really ideal situation where we will get a result potentially within 24 to 48 hours if needed on a molecular test for a sample, and that's been absolutely transformative in trying to manage people in whom you suspect tuberculosis might be a diagnosis. We make the point here that the reporting of isoniazid resistance levels is not clinically relevant, so any positives should be counted as resistance. This has been debated for a while, and we debated it again, and my understanding is that's now the practice, that reflects practice now as well. The other thing to mention in terms of access is these tests are not validated in all samples, but they can be a really useful tool, and we'd highly recommend discussion with your local laboratory. For example, being used on specimens other than sputum, so genitourinary TB on urine, you probably will need to discuss that with your microbiologist. But I recommend that can be a really useful thing to do. This is what our report now looks like. So we get the detection of TB, but also the resistance profile directly from a sample rather than from a culture, which is then needed to be put through for further testing. So this is the Gene Expert XDR test on a direct sample, and you can see in addition to rifampicin resistant, so the initial Expert and Expert Ultra, which look at RPOB mutations, this looks at not only rifampicin resistance and detection of TB, but also isoniazid, fluoroquinolone resistance, amikacin and ethionamide. And again, it's the range of samples that can be used on, but may not be validated. A faster diagnosis is really useful for patients. It's really useful for stewardship, and removal from respiratory isolation is the thing that also follows from that, which also is related to what I was talking about before. What about treatment and adherence care model shifts? So I think primarily here we've got an unchanged core regimen, 6 months of HR, ZE to HR, so altogether, so 2 months of HR, ZE, and then the continuation phase of 4 months, 17 or 18 weeks of isoniazid and rifampicin, the H being isoniazid. Shorter course therapy may be an option. We say this in a few select groups. We acknowledge that fluoroquinolone use is now, probably the horse is now bolted, and its use in meningitis has become standard. And its substitution for isoniazid and ethambutol have a fairly good base in evidence. So stopping ethambutol early, if you get those molecular testing results indicating isoniazid susceptibility, is now recommended. It also may be possible to swap the fluoroquinolone in for isoniazid, and there's a fairly good evidence base for that as well. The thing that is done very often, and there's less of a good evidence base for, is swapping the fluoroquinolone in for rifampicin, done a lot because of drug-drug interactions, particularly in the immunosuppressed population. There's a bit of an evidence gap there that probably needs to be filled. Pyridoxine, was a lot of discussion with our pharmacists on the panel about its probably being overused, in particularly with our patient groups, so it's really recommended only to use it now as a supplementation of B6 with isoniazid dosing for high-risk patients. And the final thing to mention, and this varies a bit, I think, between jurisdictions, and certainly we have not had fixed-dose combinations available in Victoria. We have only just recently been able to get those in for particular patients, but they certainly are globally widely available, and available in some states of Australia is my understanding, so we've included those. What's been taken out is intermittent dosing. You might have remembered that used to take up pages and pages of being able to give this dose 3 times a week. We don't recommend that anymore, and so that whole section has been removed, which is useful. So what about the short course treatment options? The 2 situations that are mentioned in guidelines are that based on New England Journal papers from 2021 and 22. So the Tacova study, the SHINE trial in children, looking at 4-month therapy, for non-severe drug-susceptible TB using standard treatment in a 4-month regimen, so in a subset of children. So this was looking at children across, I think, different parts of Africa, and found non-inferiority with that regimen. But again, it's just a subset, and it recommends expert advice with this. And then the other group is in adults with pulmonary TB, and this is the Dorman paper looking at the 4-month regimen trialled in South Africa. I think it was an ACG trial that used a rifapentine and moxifloxacin containing regimen plus isoniazid and pyrazinamide given daily. This regimen was kind of a bit of excitement around it at the time, the first sort of properly treatment shortening regimen to be successful, but there are a few reasons that it might not be so popular in Australia, partly the availability of rifapentine, which for us is limited. We haven't had great outcome. We can get rifapentine, but we have to apply for it. We haven't had great success with this therapy. One of the things seems to be tolerability is not that fantastic, and the other is pill burden, which is a lot of pills, so compared to standard therapy. So it is possible, it is non-inferior, but maybe not the magic bullet that we have been waiting for. That's hopefully yet to come. Adherence shifts. So we don't really talk about DOT anymore. Directly observed therapy has not been proven to improve outcomes in people with TB. We talk about treatment adherence and patient-centred care, and how we make treatment work for the patient. And often that is based at home and with patient visits. We do that a lot in Victoria with our treatment program. We have people around in the community, but the focus on observation of a dose being taken is no longer really part of that. Having said that, it is a bit of a part still of some studies in TB treatment, and so globally there's a bit of variability in this, but it's certainly no longer recommended by us. Watching people take treatment is a little bit out of favour too in other jurisdictions. So one of the things that's come into this this version of the TB chapter is a bit of a focus on side effects. Side effects are the main limiting factor. We're still at 6-month therapy. We're still using really old drugs. They cause toxicity and drug interactions. So we have suggested pre-treatment testing. So given a list for what we think that should look like. For most of you who manage TB, this will be fairly standard, but helpful perhaps to have a checklist, including for those who are not so used to managing TB. And then an overview of what monitoring might look like, what you monitor and how often you monitor. So liver function test arrangements are the main things, and this is an evolving area. We don't have good evidence for how frequently to monitor. We don't have good predictive factors to know who is going to develop LFT derangement. We know that not everyone does, and we know that it's not always predictable. And so these make it really hard. So these are just some suggestions based on what literature is out there. There's been some studies done in Vietnam in the meningitis trials looking at different strategies for managing LFT derangement, and there's some promising work there. I think it's really important to get that randomised evidence, which we're still sort of waiting for largely. Other things about monitoring and managing adverse events are mentioned, and then there's a table given to focusing on particular side effects and then what you might look for to pick them up in your screen of patients and what further assessment you might use. If you notice this, test this, and you're thinking about this, is the focus of that. And this came really from a paper that involved more than 60 to 100 experts worldwide, which I put together, coordinated in 2023, amongst the looking at this and what people do around the world. And I think the main thing that came out of that is that there's very, very big variability in what people do and almost no evidence base. But there you go. So room to improve. So long-term outcomes, there's been a lot of talk about this in the TB world. I think it's fair to say we still don't know a lot, and I think it's also fair to say that in our population in Australia, there is likely differences to some of the internationally published data, particularly about the prevalence of these things being a problem longer term. However, we should be aware of them, and in some patients we probably should think about these sort of assessments. There has been a clinical standards put up for the assessment and management of rehabilitation in post-TB lung disease, and a whole heap of stuff online and papers But I would say this is another situation of watch this space. Integrating this into program management is going to be a big step. And at the Royal Melbourne, where I work, we're talking quite a lot with our respiratory colleagues to try and coordinate some of this with them and try and work out which patients we really need to be thinking about this in. Just a quick mention, extrapulmonary TB. So we had a note from the kidney and urinary tract group that they thought this was a good thing to include, which we agreed. So we're increasingly recognising that the genitourinary system is involved in extrapulmonary TB in both men and women. And what that looks like is mentioned a little bit, and what tests you might think of doing are also given mention in our new guideline. So this is just a summary of the key changes and their impact. So terminology, aligning with the spectrum model, risk groups we talk about a little bit, and we have changed. A lot of this is around language. So we talk about adherence models has changed, TB infection has changed. The reactivation timing, so previously we emphasised that was thought to be most likely to happen early. Reactivation of latent TB or TB infection becoming disease was in the first 2 years. Previous work that's been done since then in an Australian context recognised that can stretch out to later post-migration and post-contact with the initial TB case. Treatment regimen changes, so the early stop to ethambutol limiting pyridoxine, and post-TB care and the new section on functional assessment. Diphtheria. So I think probably the first question here is why me? I was asked, when I was asked 2 years ago to join this group, the focus was really on giving Andrew Burke a hand with TB and NTM, which was sort of getting bigger and bigger to cover. And I think it was Leanne who said to me at the time, "Oh, and would you also mind taking on diphtheria? Because no one else wants to." In 2024, when that was, you can see that there was no inkling of what was going to happen with diphtheria, but it has certainly been coming to the fore. And just to mention, you'll see the little camera symbol. Please don't take photos of these. This is not yet released, but will be next week. They'll go live, so this is a prelim. Certainly when we discussed this initially, there were a few people, particularly in Queensland on the group, who'd had some direct experience of diphtheria, and the cases in Western Queensland that we know now track along to this current outbreak that we're seeing. But in April of this year, we actually reconvened as a group to try and revise these guidelines in light of what was going on in the Northern Territory and some of the data that was coming out there. On the 22nd of May, Australia's actually declared diphtheria a disease incident of national significance. So with more than 230 cases now, and this appears to still be going up. On the right, the graph here, and this is last updated on the 18th of May, so pretty regularly, you can see in blue cutaneous cases and in orange respiratory cases continually to evolve. And on the left, whilst you can see in previous years, most diphtheria cases you would see would be overseas acquired, that's certainly no longer the case. We've got active local transmission going on. I think probably the main thing for me to do here is particularly to thank the generosity of our Darwin colleagues, so Sonia Jansen, Josh Francis and Ellie Newman, who've provided most of the experience with this to contribute to the topic, and also to Ed Raby and Claire Norse and Josh Hanson, whose experience far exceeds my own and whose insights have been really valuable in trying to pull all this together. So one of the things that we've changed in this topic, this was previously a topic about, oops, I can't move forward. A topic about pharyngeal diphtheria only, looking at life-threatening diphtheria and how to stop it, and now it's expanded to also give advice on management and recognition of cutaneous diphtheria. So it gives some guidelines on what that looks like in terms of presentation, diagnosis and management. There is a photo included, I think this comes from Claire, and we talk about how it's managed. We talk about treatment only for toxigenic cutaneous diphtheria infection or if it's clinically indicated. Usually don't need antitoxin for cutaneous diphtheria, but you can get toxin production, and certainly it's possible to get myocardial and neurological sequelae, but those don't usually happen. Diphtheria antitoxin in severe disease is the primary treatment. The availability of this has been a problem in recent years, and so is now coming up as being a really important issue. Victoria has not had a regular supply. We're looking at getting one. Some of the other states more affected by this in Western Australia, Northern Territory and Queensland have established this now. The guidance on use of this and dosing is basically empiric. There's no real evidence with regard to which dose you need to use. There is a bit of evidence around how quickly you need to do it, and the bottom line for that is the quicker the better. It does prevent mortality for severe pharyngeal diphtheria, and the sooner it's given, the better it will work. It doesn't work, and this is related to its effect. So its effect is on the toxin. The toxin, once it's circulating, can be neutralised with the antitoxin, but once it enters the cell, that no longer happens. So the sooner it's done, the better. The antibiotic therapy changes have been to move phenoxymethylpenicillin, or move penicillin IM as well, down the list for this. So this is related to changes in MICs that have been seen globally. So a South African outbreak a couple of years ago also analysed these pretty carefully, and those who attended MIDGE on Tuesday this week will have seen the Darwin data, which we were also privy to, showing a movement of the MIC in the local strains that we're seeing. So amoxicillin is thought that will still be helpful given the PK around that, and azithromycin is now included as first line with erythromycin as an alternative, and this is the box taken from each Therapeutic Guidelines here. So azithromycin or amoxicillin with second line erythromycin being second line only because of tolerability administration differences. Efficacy is probably as good, and some data suggests it may be better at clearance. This is for non-severe pharyngeal diphtheria, which would be the same as cutaneous. For severe pharyngeal diphtheria, antibiotics are only really going to be helpful in combination with antitoxin. So I think that's first and foremost. The main differential here that seems to be the case in our local cases, but also probably globally, is strep pharyngitis. And so the benefit of the combination therapy there on spec, also empirically given, will also be useful hopefully with that. So that's azithromycin and benzyl penicillin in combination. We don't know about duration. Our guidelines reflects global guidance. So many of you will be aware that Europe, in particular countries such as the UK, France and Germany, have experienced outbreaks in the context of overseas arrivals, but also local spread, and they've also reviewed their guidelines. We've looked at all of those, we've looked at any evidence that there might be, and we've kept 14 days for these, which is consistent with what others do, but are aware that the evidence basis for that is not high. And then we've also included some advice about prophylaxis, and once again, the duration of this is also not entirely clear, but ours is consistent with what we see. So that's 5 to 7 days. And the choices here reflect those that you've seen previously with azithromycin and amoxicillin as number one, and second erythromycin. So I think the summary of this, the older guideline really emphasised only severe disease, so trying to prevent that respiratory diphtheria deterioration by giving benzyl penicillin, azithromycin, straight away, and antitoxin. This now extends it out, so we're looking at cutaneous disease and trying to prevent some of the transmission that's going on with prophylaxis for contacts, so it's a bigger guideline. We introduced oral amoxicillin as a preferred oral beta-lactam option, and the document actually states explicitly oral phenoxymethylpenicillin is no longer recommended due to global changes in antimicrobial susceptibility of diphtheria isolates, whereas formulations that provide greater exposure remain suitable. So this is quite a big conceptual shift. We'll wait and see what's going to happen here in Australia. The announcement of diphtheria by the Australian CDC as being an incident of national significance has led to a bit of a funding injection, so hopefully that will help. Low levels of vaccination are one factor that's led to this, but not the only one, and I think a better understanding of local factors that are leading to this situation will be really important. New guidance also repeatedly stresses culture and susceptibility testing and looking at outbreak-specific antibiograms and the evolving resistance pattern, which is going to be really important to understand in our local context. And I think, yeah, that's it. Thanks.
Thanks, Kasha. Really interesting presentation. Does anyone have any questions for Kasha? Pretty quiet from the room. I do have one question for you, which is just in your experience, which adverse effects of tuberculosis treatment are more common and tend to require dose adjustment or discontinuation?
So that's a good question. The most common things we see are gastrointestinal toxicity and liver function test derangement. And the question we always ask with the toxicity, the gastrointestinal intolerance or toxicity, we try and move doses, adjust food. We don't alter dosing. And LFT derangement, it's always trying to work out how clinically significant this is in this person. So we're petrified of LFT derangement leading to fulminant hepatic failure, but it doesn't often do that. It's just being able to pick who might be at risk of that happening and in whom this is just going to settle is really the challenge. And being able to watch people as closely as you would like to have the warning signs that might be something to worry about is the problem.
Great.
Other things that happen, but not as commonly. Yeah.
Kasha, thanks for a fascinating presentation. My question goes to diphtheria, your presentation about diphtheria, and the how you go about developing a guideline like this with a minimum, with evolving evidence, based on a live outbreak, using international experience and providing then tailored guidance to an Australian setting. Are there lessons that we've brought forward from COVID, learning that we can have live, updated, digital platform guidelines? And is the platform that TG now has enabling us to maybe modify guidance faster than we previously did in paper form?
So I think the first thing to say, I think it's a great question. It's a challenge. I think having an online platform is a really good opportunity for this. And I think the work that went on in that maybe 4 weeks was extraordinary, not just from Therapeutic Guidelines, although of course they were steering it, but the willingness of people to jump on calls at all hours from all different parts of Australia and put forward their experience and generosity. So what Darwin has been doing with the testing is amazing, and the fact that they were happy to share that and for us then to look at that and also look at the international context was amazing. People were putting sort of hours of work into this to try and look at the previous outbreaks and how they might or might not be similar to what's happening here. In terms of ongoing updates, I think that's important. One of the things that came up in discussion was how we go about generating evidence for this kind of outbreak, with the differences and similarities with COVID being brought up. I think it's really important, but it did remain a little open-ended as to what the best way to do that was. Part of the difficulty is in the remoteness of some of the cases, and that perhaps shouldn't be as much of a barrier as it is, but it is. And the focus on needing to have pragmatic solutions about availability of drugs and how many doses you were likely to be able to successfully get in. And that was also where azithromycin became important. There's quite a bit of experience with azithromycin because of trachoma as well, and I think, and maybe availability, because we don't need it for that anymore. So that was something that was also, we also thought about. But putting in erythromycin as an alternative in terms of availability was thinking in pragmatic terms. So I do think it's something we should be thinking more about, evidence, and it's a very good point. I think the way that this was updated was really good and could be replicated if need be, I think, going forward.
And then to ask a follow-up, if it's okay, was there a moment in time Was there a moment in time as an expert group or as the Therapeutic Guidelines you thought about not commenting? Because the default position is not necessarily to do. There's a position to not do when there's insufficient evidence? I mean, at what point is there the threshold to emergently reissue?
Yeah, I mean, I think I think Crispin covered a lot of this actually in his talk about evidence and what we have and what we don't have. And I think that's part of these guidelines is we do recognise evidence and it's really important, but they're guidelines more than evidence presentation. So all the evidence goes on board and the limitations are acknowledged and we give guidelines as best as we can with or without it, I think. And that's what makes, I think, the Therapeutic Guidelines a bit of a unique project. But I think, yeah, when Crispin was talking at the start of that echoed quite well with me. And I think it's also what made involvement in the guideline. We don't sit there and go, we don't know what to do, there's no evidence on this, full stop. It's not the purpose of them, I suppose, which conversely means that will be wrong, and they'll be outdated when the evidence comes. But then, hopefully, we can build in a structure then to be able to evolve them in response to that.
Alicia, I'm the senior editor who was involved in the tropical group. Sorry, it seems really loud. So I guess with the diphtheria topic initially, when it was just pharyngeal diphtheria, we did have more of a light touch approach at that point because many of the group members said that they haven't seen a case previously. So we did have a bit more of a light touch approach then. But then when we were contacted by Sonia and some other people from the Northern Territory, and we became aware that it was becoming more prevalent in Australia, we did decide to sort of evolve the product, change it a bit more to meet the needs of our users. Mel, who is here at the back, she's going to be giving a presentation shortly about a new model that we're rolling out. So that will also be able to address these sorts of situations.